Welcome back, everybody. That first session seemed to fly by. So that was our colorectal emergency session. And now we're on to what I've titled Political and Management Emergency General Surgery. It seems to feature heavily anesthetic input. And so we're off to a flying start. I'd just like to point out the Twitter polling that we're showing has taken place, and I'm afraid there isn't the opportunity for live repolling today, but the poll results will be available on the platform subsequently. So over to Professor Sagar.
Thanks, Jill. It gives me great pleasure to introduce the first speaker of this session, Dave Murray, who's been a great friend of general surgery in recent years. He's done some fantastic work with the NELA project, so much so that the president of ASGBI, Ian Anderson, and the rest of the exec are delighted to offer him, and I hope he accepts, an honorary fellowship of Association of Surgeons of Great Britain and Ireland. Dave's going to address the topic of an update on NELA. David.
Thank you very much, and thank you for the honorary fellowship, and I am, of course, delighted to accept. Okay, so best practice tariff for emergency laparotomy. 2 years on. Actually, it's 2 years on because I talked about this 2 years ago at the EGS meeting. Then it's actually only sort of 1 and a bit years through. But the key question of has it helped? Let's try and answer that. So next slide, please. So just an overview of what actually is a best practice tariff. It's essentially a split tariff that gives you a baseline payment and a top-up payment if you meet the criteria. If you only baseline payment, then that will underfund your trust. The excess payment is what you can use to develop your service. And this is kind of worked out by the NHS pricing team to be overall cost neutral to the NHS, which means that to some extent, what constitutes a best practice tariff is actually a mathematical thing as much as a clinical thing, because the NHS pricing team will take all the trusts that they expect to be participating in the NHS in emergency laparotomy and work out what produces a cost neutral tariff. I'll come on to that because there's some little vagaries that don't quite fit in a bit later on. Next slide, please. So just to, have we jumped forward 2 slides? No, okay, carry on. So I think, right, so just to give you an overview of what the actual difference in tariff looks like. It works out on average, the difference is about 700 quid. So if you've got 100 patients, 70,000 patients, £70,000 difference. This table here, just concentrate on the sort of the 2 red arrows at the top. If you've got a fairly major small bowel procedure in an emergency, you'll get about double or more than double what you get for the same procedure in a patient that's less sick. So that CC score is one of the key things about the tariff, in addition to the tariff itself. So coding's really crucial here because the fit and well patient having emergency bowel surgery with a comorbidity score right down the bottom gets less than half what someone who's sick expected to go to critical care would get. So not only do these procedures need to be coded accurately from the point of view of procedures, it's crucial to code them from the comorbidity point of view as well. Next slide, please. So it's a bundled tariff at patient level. And what that means is that 80% of high-risk patients need to get consultant presence and admission to a critical care. And it's bundled, which means patients have to get both. So you could have a situation where 80% of patients get say the high risk, 80% of high risk patients get consultant presence, and the other 80% get admitted to critical care. It's not the same 80%, so you won't meet the tariff. Next slide. The other key aspect of this, and to some extent one might arguably, the more important bit is that in order to be eligible for the best practice, you actually have to have an agreed pathway in place for the diagnosis and treatment of emergency laparotomy in your trust. And that needs to be agreed by all the clinicians involved in delivery of care. So in theory, this has pulled in discussions with ED, radiology, the usual anesthesia, surgery, critical care, and also elderly care. And a lot of this has actually been facilitated by the emergency laparotomy collaborative work done by the AHSNs, which has meant in many cases, we've actually got regional pathways that are really beneficial from the point of view of trainees rotating around, working to very similar pathways. Next slide. Okay, key thing, POSSUM is dead. Originally, we had this choice of POSSUM score and NELA score. There's been updates to how high-risk patients are determined, and it is just down to the NELA score now. And I would advise you, as would NELA, on behalf of NELA, to just use the web-based NELA risk score. The website address is down the bottom. The reason for that is the coefficients that lead into the final score get readjusted periodically. The challenge is we can't update them in the app, because apps are now medical devices. They need to get CE marked. And apparently everybody that does CE marking has disappeared from the UK and is now all abroad because of Brexit. And it's a real challenge to actually get this work done. So if you're using the apps or you're using POSSUM, please stop and start using the NELA risk score. Next slide. And furthermore, it's the highest risk of either clinical judgment or the NELA score. So if you've got a situation where NELA score is low risk and clinical judgment says it's high risk, they're classified as high risk, and vice versa. If there's been no risk score performed, then they're also classified as high risk. And this is following on and in keeping with guidance from the high risk general surgical document, and is backed up this both in last report and the current report that's going to soon to be published, that found that patients who don't have their risk of death documented have a mortality of 6%. So it categorizes them as a high risk group. Next slide, please. So what will you actually get paid for? So let's imagine you've got 100 cases in NELA. Next slide. You've actually got 105 cases coded for emergency laparotomy. Next slide. Okay, so if 60 of those cases are high risk and 80% of them get consultants and critical care, so you've met the enhanced tariff. Next slide, please. You actually get paid for all the cases that are coded as being an emergency laparotomy, not all the cases that are in NELA and not all the cases that are high risk. So it's every patient that has an emergency laparotomy gets the extra money, regardless of whether they're high risk or not, providing you meet the tariff. Next slide, please. So has it helped? Yes, I think it has. And the data backs this up. You might argue about cause and effect, but we'll come on to that. So we've been publishing quarterly reports. On the left-hand side of the screen, as you look at it, was Q4, so the last quarter, just before the best practice tariff was brought in April 2019. And around half of trusts met the best practice tariff. If you fast forward to quarter three, to the end of December 2019, we've moved to a situation where getting on for 2/3 of patients, or 2/3 of trusts, now meet the best practice tariff. So there has been improvement. Next slide, please. So if we look at the trend in proportion of patients who gets risk documented, you can see that trajectory has continued up. And next slide. And again, if you look at the individual components of risk, consultant presence and critical care admission, that trend has continued up. Now, you might argue that that trend was going in that direction anyway. Yes, it was. But what tends to happen as you get closer and closer to 100% is that trend plateaus off and it gets harder and harder to get those last few patients in over the line, if you like. So in this respect, the best practice tariff has kept the rate of change going. It's kept that trajectory going in the right direction. Next slide, please. It's not all straightforward because block contracts, and we don't actually know how many trusts are on block contract, and neither does NHS England, don't actually benefit from the best practice tariff. Unless, of course, they're on a blended payment, apparently, because if you're on a blended payment, it means you can be on a block contract, so you get paid for X amount of cases, regardless of what quality of service you're delivering, but you can negotiate with commissioners to get the best practice tariff on top of it. That's down to an individual discussion with commissioners, and we don't really know how many have done that. But regardless of whether you actually get a financial incentive, vast majority of trusts still like to be seen to be meeting the best practice tariff because it's called best practice. So they like to be able to say they're delivering best practice. Next slide. So the obligatory COVID slide, this has had obviously a significant impact on the way things have been running. NHS England suspended the best practice tariff for the first quarter of 2020 financial years and a bit. So from April to July, the best practice tariff was suspended. They also, in the early days, suspended data collection for all national audits. And then about 10 days later said, oh, actually, NELA can carry on and hip fracture and some other things can carry on collecting data. But the problem was the Q4 data submission, so January to March 2020, was actually due to be submitted in June 2020. So trusts still needed to keep on top of data collection at a time when they're getting mixed messages from NHS England to not collect data. And we actually suggested to NHS England that the best practice tariff should be suspended for Q4 because of this issue of having to collect the data in the middle of COVID. We haven't heard back from them. I suspect it has not made any difference. It's just one of those issues that I don't think, I think things should have been done slightly differently, but that was out of our hands. Next slide, please. So just to summarize, I think it has helped, and there's data to back that up. We have an emergency laparotomy pathway that is often region-wide that has brought in input from the vast majority of specialties that should be involved with emergency laparotomy care in your trust. So it's opened those discussions and conversations with ED, with radiology, with fast-track CT slots, with elderly care of how do we get geriatric input to our patients after surgery. It may well have brought in more money for your trust, depending on whether you've met the tariff, whether you're on a block contract, whether you're on blended payments and a whole host of other things. Bottom line, though, is more patients are getting their risk assessment and more patients are getting consultant presence and critical care admission. It's got another 6 months to run for the end of this year, and we shall wait and see as to whether or not it gets extended for the following year. Thank you very much.
Thanks, Debbie. That was excellent. Very helpful indeed. Very useful information. Sure, we'll come back with some questions later. Jill?
And so now we're going to hear from the National Clinical Lead for Surgical Ambulatory Emergency Care, and that's Oren Saha, who's a consultant surgeon at Huddersfield. Oren, thank you. Oren, you're muted.
Thanks, everyone, and thanks to ASGBI for the opportunity to give a bit of an update on surgical ambulatory emergency care. Next slide, please. I think it's important to see this in the context of what's been happening over the last 6 months. And next slide, please. I think for all of us on this conference, everyone who's been delivering acute services, certainly my message to all of you is it's been incredible, some of the examples of work that I've seen around the country, and I sincerely hope that you're all doing okay as we kind of start looking at how to envisage surgical services in the future. Next slide, please. For ambulatory care, we sit in the context of how the hospital looks, how the health service looks in total. An enormous amount has changed. The infrastructure of all our hospitals has changed. The staffing levels have changed. Many of our hospitals still have really large numbers of people off sick or shielding. The admissions have changed, and whereas over the first couple of months of the first spike of cases, we saw reductions in acute admissions, that has reversed and in fact rebounded. And in our hospital in Huddersfield, we're now running at about 135% of our standard number of expected admissions for this time of year. We've not only gone back to normal, we've gone beyond that. There are, of course, restrictions on PPE, and it's really important to bear in mind the health and well-being of all of our colleagues and of all of us. And of course, numerous other things which are affecting our surgical services. Next slide, please. In terms of what this means for our ambulatory units and for surgery as a whole, we now have to think about isolation policies for how we manage our elective patients and social distancing. Our ambulatory unit at Huddersfield, for example, had space for a certain number of patients in the waiting room, and that is simply not possible anymore to meet social distancing guidelines. We've got to think about shielding and testing, and of course, many other factors beyond the simple management of an acute surgical patient. Next slide, please. And so really the effect on our units means that we've got less space to manage the acutes, And combined with the increase in our emergency numbers, we have got rapid and really marked rises in elective waiting times. And we've seen the impact this has on our patients. And it's been great to see bodies such as the Royal College of Surgeons and, of course, ASGBI really stressing the importance of trying to stay on top of our elective times. But ultimately, it's not just us. There's been big increases in diagnostics and intervention. And the things that challenge us as surgeons are the things that challenge all of our colleagues in general practice, in A&E, in ED, in diagnostics, in radiology. And we're all seeing markedly reduced efficiencies and reduced staffing levels. Next slide, please. And so what this means for all of us is increasing admissions. And although it's easy to kind of bash our colleagues in other departments and other specialties, we need to remember that the same challenges face all of us. Our GPs are working harder than ever, but it's really, really difficult for them to examine patients. Our colleagues in ED are working harder than ever. And ultimately, we're all seeing delayed presentations. We're seeing patients with gallbladder or appendiceal pathology present later. We're seeing cancers which may have been diagnosed through a fast-track pathway in March, April, or May, presenting with obstruction or perforation. We're also seeing potential complications from delayed elective treatment, and as a result, markedly increased turnaround times, and which we've commented on before in previous sessions, multiple different recommendations from multiple different groups, which change often with very little notice. Just look at what's happened in the country over the last 24 hours. Next slide, please. Looking at this in the context of what's coming over the next few months is frightening. We're already seeing at the end of summer increase in our admissions, and there's no doubt that as we move into winter, there will be an increase in admissions for our medical colleagues. There will be an increased pressure on beds. And this is in a time when it's unlikely that our acute surgical admissions are going to fall. Next slide, please. And as a result, I personally think that surgical ambulatory care is going to be absolutely crucial as we try and deliver some sort of acute surgical service. So for the next couple of minutes, I thought it would be worthwhile giving an update on the various bodies and groups that are involved in surgical ambulatory care, and a bit of an overview as to where I think the real challenges will lie. The Surgical Ambulatory Emergency Care Network is run through NHS Elect. It's a brilliant programme that enables healthcare teams to rapidly expand ambulatory emergency care services. It's been running with our medical colleagues for over a decade, and we've started the surgical groups over the last 3 or 4 years. And we're about to have cohort 6 starting later on this year. Separate to the Ambulatory Emergency Care Network are the Same Day Emergency Care Group, which is a mandated group run through NHSE, NHSI. Now, these really aim to deliver the ambition set out in the NHS long-term plan. And I'm proud to sit as the chair of this group with Professor Sagar and a number of other surgeons around the country. And really, we are mandated by March 2021 to be providing surgical same-day emergency care 12 hours a day, 7 days a week in every acute site. Next slide, please. The thing that's relatively new in all of this is Think 111, and that fits into the same-day emergency care and the surgical ambulatory emergency care network. Next slide, please. The overarching principle of ambulatory care is to treat all emergency patients as ambulatory until proven otherwise. Next slide, please. Now, Think 111 is a relatively new campaign that started about 3 months ago. And this is to respond to the challenge of increasing numbers of patients in ED, and the understanding that the waiting rooms are just not kitted out for increasing patients with the likelihood of social distancing that we're going to need to do. So the aims of the NHS Think 111 campaign are to increase the percentage of patients accessing urgent care through 111 rather than ED. And for those patients who don't need emergency ED care, to try and have heralded appointments into the emergency department. The aim of this is to reduce the occupancy of ED waiting rooms and ultimately to facilitate alternative options for patients, not just general practice or ED. Next slide, please. So in terms of progress in the NHS Think 111 campaign, there have been some really successful trials in Portsmouth and London, and some integration of acute surgical units into NHS 111, for example, our unit at Huddersfield. The surgical side of this is relatively underdeveloped at the moment. As you can imagine, the main part of this is with medicine and ED, but this is going to lead to regional and STP level organisation. And there's been a load of learning that's been shared at the recent Hampshire Learning event for Think 111 towards the end of August. Next slide, please. And there are three main aims. The idea is that people who don't need A&E or ED are directed elsewhere, but also to try and use ED just for emergency patients. You can see where surgery is going to fit into this, the second aim of this. Patients who need to access hospital services to be directed to the correct department straight away and not via the ED. Next slide, please. So what does this mean for surgeons? Next slide, please. You can see that the surgical ambulatory and surgical same-day emergency care units are going to be key to delivering direct access for patients who could and should come straight to surgery. Next slide, please. I've been involved in trying to put together what this might look like for our acute site. But this means we're going to need space to assess and diagnose patients and potentially start looking at ambulatory pathways for management. Now, most of our units will say that we do this, but what does this mean for the patient? It's not right that a patient comes in, sees a registrar and is discharged on an ambulatory basis if the patient doesn't know who their consultant is, and if the consultant doesn't know the patient's ever coming under their care. Equally, there are loads of patients who are in hospital at any one time having antibiotics. We've heard already in the previous session about diverticulitis. But in our hospital at any one time, there might be 8 or 9 patients having antibiotics for cholecystitis or diverticulitis. That's half a ward. If those patients can be managed on an ambulatory basis, analogous to cellulitis for our physicians, that's potentially a big number of beds that we can release. And of course, there are already really well-established ambulatory appendicectomy and cholecystectomy models in Bath, in Cambridge, and our unit as well. We're going to need really close links with our CCGs and NHS 111, and this is likely to lead to an increase in uninvestigated patients into the SDEC and an increased number of patients into the surgical SDEC. This is the reality of where we're going. Next slide, please. Now, from my point of view, I've been trying to make sure that the things that do come through to surgery are reasonable for us to deliver. And so my plans currently are to look at wound problems and abscess. So those patients who've had an operation in our unit and have a wound problem, it's absolutely ridiculous that they have to go either general practice or to ED. And if you look at the patient journey for those patients, they have 4, 5, 6 hours of waiting before they get to see the person they need to see. Thank you. I'm trying to avoid undifferentiated abdominal pain because that's really a big group of things that don't have a surgical problem. Next slide, please. So this means for us that there are dangers. The volume of work that we're going to see is going to be ambulatory. And there is a danger that EGS jobs simply become ambulatory jobs because that's just where the volume will be. We need to be careful that we don't transfer acute cases onto elective lists. And we need to be very careful that we don't simply become an ED. And of course, look after our colleagues and our trainees. Next slide, please. So I think what this means that we have to get right in all of our units is equity amongst consultants and everyone pulling their weight with really honest and open discussions about job planning. We need to know that one size doesn't fit all. One surgical department is different to another, and think about the workforce as a whole. And I'm leading the Royal College of Surgeons Surgical Workforce Group, and I'd be grateful for all comments on that. We need to understand the pressures on all of our departments, and we need to get CPOD working better. The life or limb rules are no longer fit for purpose or applicable to today's NHS. And ultimately, consultant presence 24/7 for all of our cases. Next slide, please. Loads of resources, very happy to be contacted. I'm very happy to take questions at the end of the session. And I would urge you, if you're looking at ambulatory services, to look at the Ambulatory Emergency Care Network. Thank you.
That's great, Aaron. Thank you very much for that. Over to you, Pete. Pete, you're muted.
Sorry. We're going to move on with Michael Wilson from Edinburgh, who's going to tackle the results of the various Delphi studies that have been put forward in emergency general surgery. Michael.
Thank you. Thank you to ASGBI for the opportunity to talk about what is essentially a free advert for this ongoing project. It's supported by ASGBI and also World Society of Emergency Surgery, and I'm leading the team of Scottish surgical trainees on this project. And essentially what we're going to talk about is a research priority setting exercise in general surgery. Next slide, please. So objectives, very, very briefly, I'll mention what is a Delphi process, Why do we need a Delphi in emergency general surgery? I'll talk very briefly about phase 1, also phase 2, and then finally I'll tell you that we've launched phase 3 today. Next slide, please. So what is a Delphi process? Very briefly, it was designed to be a forecasting method in the military that aims to encompass the views of a panel of experts. Next, please. So within healthcare, it's been modified to encompass expert or stakeholder views and give them all an equal voice. And it's essentially made up of 3 phases now. So phase 1 is where anonymously you can submit questions which you think are important. Phase 2 involves ranking questions, and phase 3 is essentially a re-ranking of an edited version of phase 2. It's now accepted to be a systematic method for developing research priorities. It's not used just for research priorities, but that's where a lot of the work has been done recently. And it's now being used with increased frequency in the surgical community. So next, please. So we've heard from Nicola Fernhead already, and this is the first paper that I came across. So this was ACP-GBI using a Delphi approach to develop research priorities for their association. Next, please. And then the next 2 papers, so next again, are Association of Upper GI Surgeons. I approached them and led 4 different subspecialty Delphi exercises for them, and that's just 2 of them. And then more recently, some of you may have seen published in the BGS, a COVID-19 surgical research priority setting exercise, which was just published, I think it was about 10 days ago now. Next slide, please. So why do we need one in emergency general surgery? I think it's fair to say that we don't actually know from a consensus perspective as to where the research priorities lie. It is an evolving, exciting surgical subspecialty. From my point of view, and I might be biased, I'm still fresh blood as a consultant surgeon with an interest in emergency general surgery. And I think that gathering consensus views will help to shape this new specialty in the coming years. And also as well, I think there is evolving evidence that funding bodies like Delphi priority setting exercises, and I think in an ideal world, they are more likely to support research that has been shown by consensus view to be a priority. Next slide, please. So phase 1, next, and apologies for the animations. So this is what went out on Twitter at the beginning of phase 1, and it was very simply to say, asking the question, what do you think are the most important unanswered questions in the field? And then you were given a link to submit your questions. Next slide, next please. I think you can click about 3 or 4 times. So in essence, it opened from November 19 to March 2020. 114 people took part, and that led to the submission of 179 questions. A steering committee of trainees and experts in the field worldwide was formed. And so at the end of the editing, deleting and merging of questions, 93 went forward into phase 2. Next slide, please. The plan at the end of phase 1 was to hold a patient focus group, but unfortunately had to be cancelled because of, next, COVID, next, and all of the well-publicised problems that encountered, and obviously bringing a group of patients into the same room would not have gone down well, and probably have ended up with me being on the front page of the Daily Mirror. Next slide, please. So at the end of phase 2, we pressed ahead without the patient focus group. And so 93 questions were ranked on a 5-point Likert scale from 1 to 5. That was in August 2020. And unbelievably, out of all the Delphi processes I've been involved in, this is overwhelmingly the biggest participation I've ever seen. So 223 people took part. And just in the last few days, we've used a 55% concordance cutoff of being ranked as 4 or 5 high priority, and 42 questions are now included in the final phase. Next slide, please. So what are you going to see when you click on the link? A wee sneaky peek. So next one. I've just selected 5 random questions. I'm an upper GI surgeon, so there is no bias here. So what is the impact of emergency laparotomy on quality of life in frail patients? And I think that has links to what you're going to hear about from Julie Cornish's group later on in this session. Next one. Next. So should patients have extended VTE prophylaxis after an emergency laparotomy, whether it be resection with or without? Next one. And in relation to the previous presentation we heard, can we manage mild acute pancreatitis safely in an ambulatory setting? And who are the patients that we can do this in safely? Next slide. Just 2 more to go. And is endoscopic follow-up required in CT confirmed acute diverticulitis? Again, we've heard briefly about that this morning. And final question. Are emergency surgical outcomes improved with perioperative physician or geriatrician input? I think we do have an evolving evidence base for that question, but that's still considered to be a hot topic at this stage of our project. If you want to see the rest of the questions, then what you'll have to do is, next slide, have your say. Phase 3 is opened this morning. That's the bit.ly link that you can put into your Google search engine. So bit.ly/EGS Delphi 3, or even easier, next slide. That's the QR code. So if you take your mobile phone out now, open up your camera, put that in front of your screens, and that will take you direct to the SurveyMonkey. That's the end of my presentation.
Thank you, Michael.
Okay,
Jill.
so we next have a Twitter poll, one of our further Twitter polls. Can we have the results? So we did initially put on Twitter multiple options, but then we realized you're only allowed 4 variables. So we asked people who should be involved, and you can see quite appropriately the majority, 70% of people think the patient is key in making preoperative decision making with the consultant. Oh, that's interesting, consultant and anaesthetic split there in this session. So without further ado, I would like to introduce a good friend of mine, Dr. Sarah Hare, who is the clinical lead for NELA, to talk about shared decision making. Thank you, Sarah. Who is on mute.
So clearly you've all got the hang of this because of shared decision making, because you voted that the patient is the most important person in making their decisions when they have their operation. But what I'd like to talk to you about today is that true in emergency surgery, and how do we do it if we can do it? Next slide, please. So the National Emergency Laparotomy Audit, or NELA if you're down south, has been collecting data on patients having emergency laparotomy for several years now. And this is important because what we're doing is we're giving them a voice. We're starting to understand more about their outcomes and about their pathways and what happens to them while they're inpatients having their operation, and a little bit more about long-term outcomes. If we consider the elective surgical population, there's about 1.5 million people who have a surgery every year. And they tend to, we're not quite on the next slide, but they tend to, thank you, but they tend to have a much lower mortality, with a 30-day mortality of around about between 1% and 2%. And they benefit from perioperative pathways. They benefit from prehabilitation, from rehabilitation, from good, robust analgesia techniques. They often will have expert nurses shadowing the entire time of their patient journey. And our emergency surgical patients, particularly emergency laparotomy patients, don't tend to have that happening. So next slide, please. But over the last few years, though, things have improved for our emergency laparotomy patients. If you have emergency surgery, you're more likely to have a consultant looking after you. You're more likely to have your clinical team thinking about the risk of you dying. You're much more likely to go to critical care after your operation. And you're probably going to be discharged home sooner. Next slide. Nevertheless, as we look at our long-term data, we know that nearly a quarter of patients having emergency laparotomy surgery are dead within a year after their operation. That's all-cause mortality. And we know that 1 in 10 have died within 30 days. Many do stay in hospital for a long time, and they may require prolonged periods of rehabilitation. The impact upon their life is really quite significant. Next slide, please. So we're starting to make some progress and small steps in understanding what matters to our patients. There's some early work about collecting patient-reported outcome measures. How do we do this? How do we do this well? We're starting to even give them some information about their operation before they have their operation. We're also starting, and we'll hear from Julie a little bit later, about the long-term effects on mental health after major emergency surgery. Next slide, please. So what is shared decision-making? Well, it's really about challenging the more is better mentality and the doctor knows best tendency. Whilst many of us like that, we still need to understand that decision-making needs to be a collaborative process in which the patients and the doctors make healthcare decisions together, taking into account all of the evidence available, all of the expertise we have, whilst understanding patients' values and preferences. We're using things increasingly such as decision aids and tools to support this in elective surgery, and it's becoming more commonplace. Nevertheless, it remains challenging to do it well and consistently. Next slide, please. So it's not really only about knowledge of the operation and of the surgery. It's also about enabling our patients to understand that they have the knowledge to be able to make decisions about their own operation and their own treatment. It's not just about surgery. This is also about cancer treatment, about antibiotic treatment, about other long-term elective interventions. And it's becoming clear that shared decision-making is actually quite fundamental to be able to deliver safe and effective healthcare when there are some legitimate choices for patients to make. Once they understand that the knowledge part isn't the only important thing and factor in making decision, and that actually a patient's beliefs and preference are equally as important, the patient then will become more powerful in taking part. And we can support them by using a really simple methodology of brand, so benefits, explaining the benefits, explaining the risks, explaining the alternatives, and explaining what to do if we do nothing and what might happen. And in fact, the Osiris study, which is a large NIHR-funded study, it's been on pause a little bit during COVID, is a series of epidemiological studies looking at understanding how to do good shared decision-making in elective high-risk surgical patients. And then it will be developing a sound and robust and a methodology that we might use. So if we think about in the emergency situation, though, we probably don't have access to understanding the values, the goals, the needs and the preferences, and even the tolerance of different outcomes and the perceptions of what is a bad outcome in patients requiring emergency laparotomy. And maybe all we have is our own expertise. Next slide, please. And we can divide these two barriers to, next slide, please. We can divide the barriers to effective shared decision-making really into two different things. If we pop on to the next slide. This is the barriers from the system and the condition that the patient is suffering from at that moment, and barriers to do with our patient and clinician interaction with each other. So sticking to this no decision about me, without me, in a patient who is critically unwell, who has deranged pathology, who may have very severe pain, which we know is a real influence on decision-making ability, understanding the fact that we have a lack of time to get to know the patient, understanding the fact that we don't really have any time to understand what is their perception of a fate worse than death, what is a really bad outcome, means it's very difficult to do this well in our emergency laparotomy patients. States worse than death are an interesting thing to consider. When we think about how a patient perceives risk, it changes, and in fact, how we ourselves perceive risk, it changes accordingly to how unwell you are, how in pain you are, and how close to death you may be. And actually, something that you may tolerate when it might save your life is very different to if you consider right now, if you became a patient who required long-term ventilation via a tracheostomy, or you ended up with a high output stoma. That at this moment, sitting here fit and well, may seem intolerable. But when you become nearer to a point where that's your only option to survive, it may be that you change your perception of what is a fate worse than death. In an emergency situation, how can we explore that quickly and robustly? Is it possible to do so well in a position in emergency surgery? Next slide, please. This is taken from some work done in emergency medicine and emergency departments about how could we do this? Is it possible in emergency medicine? And I think it's a good summary of how we should potentially take this forward when looking after emergency surgical patients. Is there clinical equipoise around the case? Is there more than one reasonable option? If yes, then is the patient able and willing to participate in the decision making? Is there enough time to engage the patient in any discussions? If you answer yes to those in the clinical situation, then perhaps it is appropriate to start exploring making shared decisions about the next steps in this patient's care. However, if there isn't any other reasonable option, and this is where we need to start understanding futility in emergency laparotomy, then we need to start moving down different measures and understanding how we can say no to emergency laparotomy compassionately and take informed consent and make sure we've understood all the options available to the patient. This model is perhaps one that we need to develop more as we look after emergency laparotomy patients, because actually putting them through high-risk emergency surgery and all the significant strains afterwards may not be the right thing to do. But how do we communicate that well with our patients? So next slide. Shared decision-making is clearly a challenge in critical illness. It's something that's very difficult to get right, but we probably have power in working as a multidisciplinary team to do this. I was a bit, I mean, I guess it's the audience, but only 5% of you thought the consultant anaesthetist and the consultant intensivist should have anything to do with this decision. But I probably would suggest to you all that standing at the end of the patient's bed in the middle of the night when you have a predicted mortality of over 10% is probably made easier if you stand there with your team next to you. Saying no and exploring options is easier when you have more of you together. And actually, using our knowledge about intensive care and what happens during critical care and the long-term outcomes is probably quite useful. We should get our basics right. Those simple things such as introducing ourselves by name, making sure we have good privacy, getting the analgesia right so a patient is able and not just willing to participate in discussions about that treatment are very key. We have to invite the patient to be involved. We need to grant them some permission, and that comes back to knowledge and power, empowering them to be able to take part in those. Often patients describe in the studies that have been done on shared decision making that they cannot, they do not want to challenge a doctor. You know, he's a good doctor. I don't want to say anything against what they've got to say. How can I disagree with them? This isn't just saying yes to surgery. This is also saying no to surgery. We need to ask them if they want to have someone with them as we have these conversations too, so that they can help recall them. In our early, some of our pilot work with our emergency laparotomy patient focus groups, many of them have absolutely no recollection of any discussions about risk or even signing their consent form. So therefore, thank you. And we need to be able to offer them both explanations and options. We have to make every contact with them count. And using decision aids may be something, but also using that simple tool of brand. So explain the benefits, what are the risks, what are the alternatives, and what happens if we do nothing are really very important. So next slide, please. So ultimately, putting your data into the National Emergency Laparotomy Audit is key to help us drive this forward any further. Without understanding what's happening to our patients and getting this snapshot, we can't really do shared decision making effectively. Thank you very much.
Thank you, Sarah. That was great. Agree completely. You should have your friends there at the end of the bed. Over to Professor Sagar.
Well, very nicely, we move on to the role of age and anaesthesia in this story. I'd like to hand over to Tanuja Shah, anaesthetist from Derby. Tanuja, please.
Hello, and thank you for listening, tuning in. My name's Tanuja Shah. I'm a consultant anaesthetist at Derby and current president of Age Anaesthesia, and also occasional running partner of Miss Tierney. I'm not sure which one of those has qualified me for this. Next slide, please. So there are loads of considerations with older patients, and I'm not going to go into most of them, but what I wanted to do was pick a couple that I thought were pertinent that you might not necessarily be thinking of first of. Next slide, please. So, first of all, not all old patients are frail. This lady apparently is in her 80s, which I find distressing and frankly unfair. But what I want to do is to talk to you about what's useful to know in a time-pressured situation, because often with emergency general surgery, that's what it is. And for each of those, and these are my personal views, I'd like to stress, for each of those, I'm going to talk about how you as a surgeon are going to know this, and then why do we actually want to know, and does it really change anything, because that's important as well. Next slide, please. So the first one that I picked was cognitive impairment and the risk of delirium. So delirium used to be one of these things that we, kind of considered almost part and parcel of being old and having surgery, and especially emergency surgery. But in the last sort of, decade plus, much more than that, it's certainly emerged as being something that should be imminently avoidable. It's very much thought to be detrimental, described as like a bushfire in the brain or a acute brain failure. And we know that your risk of delirium increases if you suffer with delirium. It increases your length of stay. It increases your mortality. So for every 48 hours of delirium experienced, your mortality risk goes up by 10 to 20%. And we also know it doubles your risk of post-discharge institutionalization, and also your long-term risk of dementia by 10%. But what can we do? Well, how do you know, first of all, whether somebody has cognitive impairment and therefore at risk of delirium? Well, firstly, it may be blatantly obvious, and we're not going to really dwell on that. However, collateral history can be really important, and it's the patients who perhaps relatives describe as maybe being a little bit forgetful recently, or if you look in their notes or electronic or paper notes and they might have had a sort of referral to a memory clinic, those are the patients who might come across as absolutely fine when you see them, but underneath they're paddling and treading water to stay alert and with it. Why do we want to know as anaesthetists? Well, we want to mitigate the risk. We can't turn it off. We can't reduce the risk of delirium to zero, but there are things that we can do. For some operations, we can avoid a general anaesthetic, but sadly, most of the operations I think we're talking about here, it's unlikely. We can modify drugs, and there are certainly some commonly used drugs that we can avoid. For example, something like cyclizine is one to avoid. Depth of anaesthesia monitoring is something that might prove to be useful, and there's some evidence that actually making sure that your patient isn't too deeply anaesthetised reduces their risk of postoperative delirium. Now, this doesn't mean they're going to be awake or unanaesthetised. It just means that there's a spectrum and we're keeping them on the sort of slightly lighter end of this spectrum. Next slide, please. This is also something we can do. So this is actually, would you believe it, a clock? It is a clock, but it was taken, it was on a wall in a high care post-surgical area. And I would challenge most of you to look at that and not feel slightly confused, particularly if you're at risk of delirium. This was actually pointed out to me by one of the surgeons. It had been a gift by a patient, and a nurse had popped it on a wall. These sort of things, so orientating your patients afterwards, is one of the things that we can do. Next slide, please. So my number 2 thing is frailty, and it's great to hear that having been brought up already. It is a real thing. We talk about frailty, but actually it's becoming much more defined. How do you know if your patient's frail? Well, again, it might be blatantly obvious, and again, that isn't necessarily the patient we need to know about. But frailty scores are becoming more common. So on the slide, you can see the clinical frailty scale, and I really like this one because it gives you pictorial, numerical and descriptive ways of defining frailty. But there are plenty of other frailty scores available. The Edmonton frailty scale is around, and many others, and it doesn't really matter what you choose, but it gives you a way of describing things. The gold standard in frailty is always thought to be the comprehensive geriatric assessment, but in an emergency setting, most people aren't going to have access to that. You may, though, have a recent admission where one has been done, and that can be really useful. So why do we as anaesthetists want to know that? Well, there is clear evidence from many sources, including the ELF study, which is from NELA, the Emergency Laparotomy and Frailty Study published last year, showing that increased frailty, and that's across all ages, increases your risk of mortality and morbidity. And at an early stage, it allows appropriate discussion, and it's great to hear about that from Sarah, and that those things are becoming more common. Next slide, please. So again, not all old people are frail, but we are seeing an aged population with increased frailty, and you're more likely to be frail the older you are. Next slide, please. The third thing that I picked are sort of end-of-life plans, and I think this is probably a little bit controversial, but it was very interesting, again, to hear the shared decision-making talk and these sorts of things being discussed. So I put, it's not really the time to be having this discussion, and we'd hope that maybe these have happened before, but I really take the point from the previous talk that actually your perspective may change when you're faced with certain things. How do you know if your patient's thought about this? Well, it may be in the notes, or this is an example on the slide of a respect form, and these are given to patients. It's something they discuss in advance and have a think about, and it just opens up the conversation. If you want to open up the conversation with relatives, it's important to sort of phrase it appropriately and thinking about, for example, did your mother ever say what she'd have wanted in such circumstances, is an important way, rather than saying, what do you think? Because it takes the pressure off the relatives. Why do we need to know? Well, contrary to popular belief, it's not that we want to sort of cancel everything and abandon things, but I think it opens up a really important conversation between the patient, the surgeons, the anaesthetists, the family, post-operative care. And I think they're all important, though I totally go with your Twitter poll that the patient, if possible, is the important person in all that. And it kind of allows us to sort of make appropriate decisions at the levels of post-operative care. Next slide, please. So just, I know this is sort of a little bit ahead of time, it's quite a quick talk, but I kind of summarize these in the 3 or 4 Ds, if you like, to consider. And if you can take this away, this is great. So you've got number 1, think about the delirium risk, and that's thinking about any early dementia or signs of confusion. Are they delicate? That's a bit of a fudge, but you know, frailty, that's important. And any sort of directives, has your patient given any indication of their views on this? Next slide, please. And that's really all I've got to say. I think we're taking questions at the end of the session, so I'd just like to thank you for listening. Bye-bye.
That's great, Tanuja. Thank you very much. As with all things anaesthetic, ahead of time is always good for a surgeon. Over to you, Pete. In fact, that's not true at all. It's back to me, Jill.
Back to you, Jill.
I'd now like to introduce another good friend, Julie Cordish, who's a consultant colorectal surgeon from Cardiff, and she's going to talk to us about the concept, which we all may have by now, of PTSD in emergency laparotomy patients. Thanks, Julie.
Thank you very much. So first of all, I need to make a slight apology in the fact that my next door neighbours appear to be having significant building work. So if you hear banging, it's not my children being locked in a room, it is in fact the building. So we'll see. So yeah, can we move to the next slide, please? So I've been asked to talk about psychological outcomes after emergency laparotomy, more specifically PTSD and post-traumatic stress disorder. And when we think about PTSD, the first thing that usually springs to mind is war, you know, soldiers coming back, people who've been victims of bombing, you know, violence. But I would actually argue, next slide, please, that a lot of those impacts are for our surgical patients. And the effect of PTSD and some of the psychological components are significant. So people with PTSD can have an emotional vacuum around them. They feel isolated. They can't interact with others. Relationship work is affected. They can't concentrate. They have insomnia with flashbacks, nightmares, and they can get panic attacks, acute anger sort of issues, and significant depression. Next slide, please. So when we look at what the risk factors are, I'm sure that you would look at this and say that many of our emergency laparotomy patients in particular, but all surgical patients generally, are at risk of PTSD. You're surviving, we hope, a traumatic event, having been hurt. You can feel extreme fear, vulnerability, you don't know what's going to happen. And patients may or may not have social support after the event. Now, this can happen immediately, or it can happen several months or years later. Next slide, please. So treatment can depend on how severe the symptoms are and the social network of the person. If they're very mild, then counselling, talking to friends, family, and watchful waiting may be sufficient. Antidepressants can work for those patients who have the depression component, but all too often GPs can prescribe antidepressants for these patients, not really recognising that in fact cognitive behavioural therapy or rapid eye desensitization may be more appropriate, and these are effective treatments. Next slide, please. So I got interested in this after listening to a radio programme, and I thought, I was listening about PTSD thinking these do apply to my patients. And I couldn't really find a huge amount of work out there. specifically on sort of general surgery, other than ones that were based around intensive care alone. So we decided to get a little bit of background information. It's not the most robust study going, but we did a retrospective cohort study of 4 hospitals in South Wales who'd undergone emergency and elective surgery for a 2-year period with bowel resections. And we sent them screening questionnaires that were used in primary care and within psychiatric departments for anxiety, depression, and PTSD. Next slide, please. So we had over 1,000 patients with a 30% response rate, not brilliant, but it's a postal questionnaire 2 years down the line. About half of the patients were male, 60% had undergone surgery for cancer, and only a quarter had had surgery for emergency surgery. Now, this is important when you then look at results. Next slide, please. Despite the fact there were so few patients that had had emergency surgery in comparison to the main cohort, they actually comprised the vast majority of those patients who had psychological problems. So 20% had anxiety and depression, and there were 14% that had PTSD on the screening. And when you look at those risk factors for it, emergency surgery played a role. Younger patients for those benign conditions, those with stomas, and those who had a critical care stay. In multifactorial analysis, younger age and female gender were the most significant risk factors. Now, there is work out there looking at intensive care stays. And for some of you, you may have units that have specific clinics for those patients who've been in ITU for a length of time. So we tried to refer these patients who'd been diagnosed to their GPs and to the specialist clinics. And they weren't able to fulfill the criteria. So GPs wouldn't accept them for primary care counselling on the fact these are complex patients and deemed to be secondary care patients. And when we tried to refer them to the intensive care clinics, we were told that the criteria for that was they had to have been in ITU for 5 days. So this is a forgotten group. They don't fulfill any of the current criteria system. Next slide, please. So following this, I wanted to look at more specifically the emergency patients. And we've conducted a focus group with 10 patients and then a further focus group with another 10 patients who had had emergency laparotomy for a variety of conditions using men and women, different ages, different conditions. Next slide, please. And the key thing that came out of the group was about communication. They felt they were on a conveyor belt, that they were moved from place to place. They'd come into A&E, they'd gone to the surgical assessment unit, they'd gone to theatre, they may have gone to intensive care, they'd gone to a ward, they may have changed wards. They didn't see the same staff the same way through. They often didn't see the same team, they weren't getting information, they didn't see anyone. Actually, the best results for those patients who'd had cancer and who were on intensive care for a longer period of time, because they were the ones that either had the nurse specialist to follow them up, or they had one-to-one nursing care and developed the rapport. And they felt it was a non-therapeutic hospital environment for their recovery. Next slide, please. For me, not unexpectedly, those patients who had a stoma and those patients who developed a hernia were the ones that seemed to have the most problems afterwards. Next slide, please. Some interesting things that came up that I hadn't really considered. So somebody had been unable to access PIP benefits because of the fact they had difficulty accessing a discharge summary that actually told them what their condition was. So the impact on these patients' finances, on their return to work, return to normal activities was significant. They were told about the risk of hernia prevention, but they weren't told how to prevent it other than just don't do any lifting for 6 weeks. Stoma management was good in the acute setting for the majority, but once they left the sort of the acute setting, community stoma nurse support wasn't always available. They didn't feel that they were told enough about what to expect. They got very, very varying information about diet with often contradictory advice from different bodies. And they didn't know how to sort of let their family and loved ones and work know, and they had no access really to psychological support and information. Those patients that had cancer did have access through the charities, but they were in the minority. Next slide, please. So I was working with I'm working with a consultant called Jonathan Bisson, who's a psychiatrist with a background for the military, who specializes in PTSD. When we initially started this work, the thought was that we would be looking to maybe do an intervention of an online cognitive behavioral therapy and rapid eye desensitization. But actually, following the focus groups, we took this further back. And it seems to be that the requirement is about an intervention in hospital with information and access to online support. So we've designed the POLO study. The protocol is being developed. We're in the process of applying for funding when, unfortunately, COVID has happened and has put a slight kibosh on all of that. Now, the idea of this was that we would work with NELA to identify those patients undergoing emergency laparotomy and randomize them to access to the information in an online or paper setting, depending on their access, in hospital, giving them key indicators at 6 weeks, and then looking at their quality of life, and also things like access to services, pain requirements, employment activity for 12 months following. Next slide, please. So COVID hasn't really just had an effect on our research. It's also, I think, had an effect on those patients undergoing emergency laparotomy, because that fear of attending hospital with COVID has made any emergency admission all more traumatic. They are far more likely to be presenting as with complications as a result, which means their stay may be prolonged. And when they're discharged, accessing hospital services and having contact with professionals is much, much more difficult. With social isolation, worries about COVID, they're likely to have less of a support network. So I would argue that COVID is going to become even more of a problem for us. Next slide, please. Now, you could argue this is a bit touchy-feely. Next slide, please. But one slide back. What we are trying to avoid is actually the tsunami of complications that are going to result. Now, Neela has done a fantastic job of reducing mortality. And like cancer surgery, as the focus on has the improvement in mortality and morbidity improves, what we now need to look at is what are the outreaching complications, what are the long-term effects on quality of life and functional recovery to make these people part of society again. So I think that's something that we need to start looking at now. Next slide. Neela are expressing an interest in developing support groups locally, and that's something I would encourage you to be doing. But we need to have more information on what patients want help with, because it is variable and very individual. And then we need to be able to identify what outcomes to measure. Potentially with COVID, with the rapid uptake of virtual technology and the increasing use of hospitals with apps and information on websites, there is a potential to improve this, but I suspect we're going to need more. Next slide, please. So in summary, I think that there are significant mental health issues that are following post-abdominal surgery that we aren't recognizing. We don't have facilities that support patients for this. And actually, in terms of just improving the situation, the first thing we need to do is recognize that there is a problem. Although the support generally is for cancer patients, some of those patients prolonged ITU stay, patients who have emergency laparotomy, they may only stay in high dependency unit for one night and therefore wouldn't actually fulfill the criteria for support following. So those patients who are younger and emergency patients are going to have a worse outcome potentially. We can look at things like if we gave them more adequate analgesia in hospital, would that reduce their incidence of dependency upon chronic painkillers ongoing in the future? What about their service use, their reintervention rate, their development of incisional hernias? Patients want information and signposting, and COVID has made everything worse. One of the things I sort of like to share, so I had two patients that I did an emergency Hartmann's on and subsequently reversed, and both of those patients came to the focus group. They were both similar ages. They had initially been overweight men who'd had the Hartmann's, and post-reversal, there were two very different outcomes for them. One gentleman had lost weight, a lot more active, and he had actually said that this was the best thing for him. He'd stopped smoking, stopped drinking, got healthy. The other chap had developed PTSD with hallucinations, flashback. He'd lost his job. His wife had left him. He was having major issues. He developed obesity, peristomal hernia. These people's lives separated like this after the same result. One person had a social network, one person didn't. We can change this by improving some of these outcomes. Thank you. Next slide, please.
Thanks, Julie. That was very thought-provoking. And the final speaker for this session is Daniel Milner, who's going to address the topic of novel technologies. And then we'll have some questions before lunch.
Thank you very much, Peter, and thank you very much to the ASGBI for giving me this opportunity to talk about some of the latest technologies. And also, I'm going to talk about some of the latest evidence now that we have for our wound closure portfolio. I think, as my colleague said previously, constantly over the last 100+ years have developed technologies to help improve patient outcomes, and no more so than in sutures. Now, we're really looking to try and go a little bit beyond what we've got already. We want to try and prevent those adverse events that a lot of you have already talked about today, and really kind of protect those patients for the future. Now, just to kind of set the scene, you know, I had a look at some of the latest evidence, and you can see just by looking at what's out there being published, that you still up to about 3.5% of midline incisions will result in a dehiscence. Up to 19% will result in an SSI, and up to 23% of midline incisions are resulting in incisional hernias. And it's fair to say that they're very much interlinked and have play upon each other in terms of having an effect, such that, for example, if you've got an SSI, twice as more likely to have an incisional hernia and 6 times more likely to have a dehiscence. Next slide, please. So one of the main, now I'm sure most of you will be aware, because this technology has been around since 2002. So for the last 18 years, we've had an antibacterial suture, the triclosan impregnated suture. Now, since that day, we've had hundreds of published RCTs on this, and I think the latest count is we've got 18 meta-analyses that have been published on this data, and through that we've had recommendations now for this technology from the 3 global health authorities you see there. In particular, I just want to pick out the WHO. They did their meta-analysis in 2017. Zhong is the author, and they came to the conclusion that triclosan-coated sutures would reduce the risk of SSI by 28%. They also did a trial sequential analysis, which meant that they suggested by that any future studies would not significantly affect that final result of 28%. And indeed, out of the 17 or so meta-analyses that have been done, they pretty much come out at the same kind of figure of 28%. Also, in terms of updates, we've recently had, well, last year, NICE updated its guidance on surgical site infection preventions and included the statement that antimicrobial sutures are recommended for use, should consider using antimicrobial sutures, sorry. And now that one paragraph behind it is actually an over 100-page document just for that one, picking up that one paragraph. And you know, one of the questions I would ask with all this evidence is, if you're not currently using antibacterial sutures in your practice, why not? And in fact, one of the comebacks I always get from my customers is that it's often a finance issue. Well, NICE, in that 100-page document or so, have actually very kindly put together a business case for us. They actually worked out that cost benefits are that additional cost of suture is 80 pence, whereby the actual cost of treating a surgical site infection was £3,125. So there was a clear to them cost benefit of adopting this technology. This is not where it ends. So I think really, you know, the question is, why is this not a standard in hospitals, a standard of care in hospitals? I'll leave that one with yourselves. Now, move on to the next slide, please. So the next part is talking about the latest developments in technology of wound closure. One of the issues we talked about there is dehiscence. Now, probably most of you are aware of Bob sutures. We have taken this to another level with our Stratifix Symmetric tissue control device, which you can see a diagrammatic picture of here. It's made of PDS. We position this for pretty much fascia closure where there is areas of really high tension, such as midline closure. Now, it is as standard impregnated with the antibacterial agent, so you get that as part of a standard with this suture. But unlike most barb sutures, you can see from the diagram there, the barbs are not actually cut into the actual core of the suture, but are actually integral to the core of the suture, which provides incredible strength. Recent study on midline closure from Madrid, and it was published in the journal for the American College of Surgeons, and this is published this year. They compared, this is a prospective randomized control trial. They compared 3 study groups. They had a group of standard loop PDS. They had a group with the triclosan impregnated loop PDS, and then they had a group using the Stratifix Symmetric. Now, not surprisingly, two groups which had the antibacterial suture both showed significant reductions in surgical site infections, and the group which had the Stratifix Symmetric, this new suture, and they showed a very significant reduction in the amount of evisceration that occurred. So really, in a nutshell, 3 things with this suture that we're really looking at. It's the security, the tissue holding strength, the lack of knot, so you don't get the knot-related complications. Because of its design, you get a real consistency. There's more points of fixation. So those patients with compromised wound healing who have poor tissues, this gives you a much better strength in tissue holding and an efficiency. Because there's no knots, it's actually a little bit quicker. And also you don't actually need an assistant to follow on as well, because it holds the tissue as it goes along. So that's pretty much it from my perspective. If you move on to the next slide, please. If you want to find out any more information about anything which I just discussed, please reach out to any of my colleagues or please scan the QR code, and we'll be more than happy to answer any of your questions. Thank you very much.
Thanks, Daniel. I think, Jill, you're going to take a few questions from the floor to finish off with.
I'm going to. So I think we've got a little more time because we've got a long lunch break. So we're due to finish the question session and finish at 1, which is only 4 minutes away. I might take an executive decision to stretch that by about 5 minutes if we have an appetite for that. So questions coming in, I've worked out why they keep changing. People are voting which questions they would like to be asked in a pecking order. So a lot of excitement to Orin. If ambulatory units become consultant-led, is there a danger that registrars lose that vital assessment and decision-making opportunity that SAU usually gives?
Yeah, there is. There's no doubt about that. And that's why it's important for departments and supervisors and trainers to get ahead of that. What we need to be sure about is that doing things without having anyone look at you isn't actually training, that's just doing. And so if every consultant is leading a unit, having a registrar with them to make the decisions and then be able to feed back on that in real time is how we need to make this work properly. But yeah, that's absolutely a risk, yeah.
Okay, well, thanks very much for that. One for Sarah. Older patients who require emergency laparotomy and have underlying illness might have long-lasting postoperative cognitive dysfunction, and it's keen to know how you balance that risk of not operating versus giving them a long-lasting cognitive impairment.
That's probably a question that takes a long time to answer. I think it's a difficult one, isn't it? Because you have to understand what the risk factors are for postoperative cognitive dysfunction, with which Shuja presented in her presentation. And you have to balance the impact of that on the family, on a care home, on that patient's own wishes. And also, as we look at postoperative cognitive dysfunction, understand which parts of that are modifiable from an anaesthetic point of view. So is it down to acute derangement in physiology? Is it due to the lack of analgesia? So balancing that at the time, it is very, very difficult. And I think you have to put the whole clinical picture in alongside that, because if that's a patient with multiple comorbidities, then perhaps it becomes, I don't think you would change your whole decision making just because the patient is going to be confused afterwards. But if you put that with their whole lifestyle of where they live or where they lived before, and what their expectations are, then you need to balance your decision making in that way.
Excellent, thank you. And one for Julie. That's an excellent talk on PTSD. How do you think they can improve psychological care for patients in our units? Is there a case for a specialist post-op emergency laparotomy nurse? Yes,
probably. Although when we first discussed this, the issue around sort of introducing a specialist nurse without any evidence behind it meant that we're starting small. But I think long term, yes, that would affect the continuity of care, the information, the access to services afterwards. I think that's probably where it's going to go.
That's useful to hear. One for Michael, 40 research priorities looks like an awful lot of work. Are you sure that they're all getting carefully scrutinized when the Delphi exercise takes place?
So they go in front of a steering committee and agreed by consensus, and then there is the concordance and the cutoff, and we won't publish 40 in the end. We will produce something like the top 10 to 15, and then it's up to the members to proceed with going ahead with answering the question or not.
Okay, that's excellent. Little bit again to Oren. So Oren's, I have to say, has stimulated that, well, it overran the most, but it's also stimulated the most questions, which says the move to avoid general practice and avoid ED is going to completely change the dynamic of the system. And actually, are we going to get a burden of patients that we really should be having? Are we not almost reinventing ED?
Yeah, and it's funny, on the kind of in the bigger talks that are happening for various NHS groups and same-day emergency care groups and the 111 service, that's been a lot of the discussion in general. And so, for example, the ED colleagues will say, if someone is able to wait for a heralded appointment in ED, do they need ED at all? Are we not just simply inventing what general practice do? General practitioners are saying, well, actually, we're pretty slammed. We've been working harder than ever. So there isn't any doubt that there probably is going to be some reinvention of what's happening. But that's not only because of what we have to do now for shielding and for social distancing, it's also an acceptance that the way we've done things previously is probably quite old-fashioned now. And we are having patients waiting in EDs and general practice for longer than they need to.
Okay, and then one probably for Tanuja is, I'm not sure if this is a philosophical, rhetorical question. Do surgeons not rate anaesthesia or ITU input into shared decision making? Is it that hard to get out of hours senior input at night? Any thoughts, Tanuja? Do you rate your surgeons?
Sorry, just is that from your poll, do you think?
Yes.
Or
do you,
is that? Yeah, I do think, and I know you agree with this, that actually the conversation is really important to involve as many sort of parties as possible, and that can be really incredibly useful. And, perhaps sometimes going to see your patient together, surgeon and anaesthetist, is incredibly helpful. And I think we need to do more of that. We need to work much less in isolation and much more collaboratively.
Okay, that's great. Are these antibacterial sutures widely available as a question? But I don't think we have our corporate on the panel. I can't see the tiny thumbnails, but you can email that on the sponsorship part of the platform, and I'm sure they'll be back to you in a flash. Great.
Hey, Jill, yes, they are. They're available through NHS supply chain. Everywhere. Yeah.
Great presentation from Julie Cornish. Were there any age differences in those who got psychological distress, upset?
So it is greater in the younger patients. And I think, from the focus groups, what I would say is it's a more unexpected event when they have an emergency laparotomy, and that may have some degree as to why they're more traumatized.
And then probably for Oren, any special advice about pain relief in an ambulatory setting?
So a couple of things. The key thing is to get nurses involved, I think, because there's loads of patient-directed analgesia that can be prescribed by nurses that reduce the waiting time for patients, and also to think about different methods of analgesia. So we all know about rectal, Voltarol, for example, really good for biliary pain, and that gets patients home a lot quicker.
Okay, so this would be the point in a live meeting, wouldn't it, where we'd normally all bunk off to the pub and nobody would come back after lunchtime. But thanks to modern technology, you're all going to be back here promptly at, she says, 5 to 2 with raised blood sugar and an emptier bladder. I'm just going to hand over to Professor Sagar for some words about any other activity that might be happening.
Oh, yes. ACP have got their colorectal live starting at 1 o'clock. So you can pop onto the ACP GBI website if you wish to see that instead of having lunch.
All right, we'll see you all again at 5 to 2. See you later. Thank you.
Thanks,
to all
Jill.
our speakers.